Let's dive right into the clinical morphology framework for diagnosing high-yield dermatology presentations on the USMLE Step 2 CK exam. We're breaking down the exact decision logic you need to know.
Starting with transient wheals, which means we're talking about urticaria. Fundamentally, this is driven by mast cell histamine release, and that immediately causes localized dermal edema. The key to distinguishing acute from chronic urticaria is strictly duration. Acute urticaria resolves in under 6 weeks and is often tied to very specific triggers. Think medications, insect stings, or infections. On the flip side, chronic spontaneous urticaria persists beyond that 6-week mark. Interestingly, up to 80 to 90% of these chronic cases are entirely idiopathic, or they're linked to autoimmune or atopic disorders. But remember, in both presentations, the individual wheals themselves still resolve within 24 hours.
When it comes to management, your initial treatment across the board relies on second-generation H1 antihistamines. Now, if you're dealing with moderate to severe symptoms in an acute setting, you'll want to escalate. Do this by adding H2 blockers or short courses of oral steroids. For chronic cases that just aren't improving after 2 weeks, consider bumping up that H1 blocker dose, sometimes up to 4 times the standard amount. You might also add a first-generation H1 blocker at bedtime, throw in a leukotriene receptor antagonist, or utilize a brief steroid course.
Let's look at a classic test-style example. A patient develops pruritus and multiple urticarial plaques right after taking amoxicillin for a sore throat. Their lungs are clear to auscultation, and there's no stridor. Because there are absolutely no airway or systemic signs here, you're looking at a mild drug-induced type 1 hypersensitivity reaction. You manage this with antihistamines and, of course, immediate discontinuation of the offending medication. Just keep in mind, if airway swelling or hypotension were present, you'd immediately reach for epinephrine.
Moving on to fixed plaques. Fixed plaques with scale are the classic presentation of plaque psoriasis. You'll see well-defined erythematous plaques with a very distinct silvery scale. Looking at palmar psoriasis, you'll spot these clearly demarcated red plaques, and you'll frequently find those thick, silvery scales sitting right on the elbows. These characteristic lesions predominantly show up on extensor surfaces, like the knees and elbows, but don't be surprised to see them on the hands, the scalp, and the back as well. It's crucial to remember that psoriasis is a systemic inflammatory disease, not just a skin condition. For instance, psoriatic nail disease commonly presents with nail pitting and onycholysis. You absolutely must actively screen for essential extradermal manifestations too, like conjunctivitis, uveitis, and psoriatic arthritis. Treatment really hinges on the extent of the disease. Your first-line localized therapy uses high-potency topical corticosteroids, often paired with vitamin D analogs. But for extensive or refractory disease, you have to escalate. That means moving to ultraviolet phototherapy or systemic agents like methotrexate, calcineurin inhibitors, or biologic agents. Next up is central facial erythema. Persistent central facial erythema and flushing is the absolute hallmark of rosacea. It distinctively presents with telangiectasias, papules, and pustules. But notice what's missing: comodones. That lack of comodones is exactly what differentiates rosacea from acne vulgaris. When evaluating these patients, you have to identify the specific environmental and dietary triggers that are inducing that facial flushing. Common culprits include elevated body temperatures, whether from heat or exercise, as well as hot drinks, spicy food, alcohol, and direct sunlight. Ocular involvement is a frequent and high-yield complication to watch for. Patients might complain of a burning or a foreign body sensation in their eyes. Clinical findings can span from conjunctival hyperemia and lid margin telangiectasias to blepharitis, keratitis, and even recurrent chalasia or corneal ulcers. The treatment ladder here starts with general measures: strict sun protection, trigger avoidance, and using gentle cleansers. For the erythematoid telangiectatic type, you'll use topical bromonidine or laser therapy. If it's papulopustular rosacea, first-line treatment shifts to topical metronidazole, azelaic acid, or ivermectin. And if they have those ocular symptoms we just talked about, they'll require specialized therapies like lid scrubs and specific ocular or systemic antibiotics. Now let's tackle oval and greasy lesions. Oval trunk lesions and greasy scaling map directly to 2 main diagnostic categories: pityriasis rosa and seborrheic dermatitis. Pityriasis rosa typically follows a viral prodrome. It kicks off with a singular, annular herald patch right on the trunk. Then, days or weeks later, it disseminates into smaller oval lesions that follow the skin tension lines. This creates that classic Christmas tree distribution on the back.
Management is mainly reassurance, since it spontaneously resolves, though you can use antihistamines to help with the pruritus.
Moving to seborrheic dermatitis, this presents in infants as cradle cap, featuring yellow, greasy scales right on the scalp. In adults, you'll see erythematous, pruritic plaques with that same greasy yellow scaling, but usually on the central face, scalp, ears, and chest. For adults, treat with topical antifungals, low-potency steroids, or calcineurin inhibitors. Infants, on the other hand, often just need emollients and a gentle shampoo. Here's a critical exam point. A sudden, severe eruption of seborrheic dermatitis in an adult patient is a massive red flag. It strongly correlates with CNS diseases like Parkinson's disease, and it absolutely mandates immediate clinical suspicion and screening for HIV infection. Let's transition to keratotic and dry skin. Conditions characterized by altered epidermal maturation will present on your exam as either localized keratotic lesions or diffuse dry skin. A prime example is seborrheic keratosis. This appears as a benign, greasy, brown lesion, and it's most commonly seen in the elderly population. Clinically, it famously resembles a stuck-on piece of wax. The diagnosis is clinical, and standard management is to simply leave it alone unless it's actively changing. However, you must know the laser trellis sign. This is the rapid, sudden onset of multiple seborrheic keratosis. It's a high-yield physical exam finding because it is highly suggestive of an underlying internal malignancy, most often located in the gastrointestinal tract. Then we have ichthyosis vulgaris, which results from a genetic loss of filaggrin. That loss heavily impairs the epidermal barrier, producing a lifelong pattern of diffuse, dry, scaly skin that notably gets much worse in the winter. It favors the extensor extremities while completely sparing intertriginous areas. Also, it's highly associated with palmar hyperlinearity, keratosis pilaris, and atopic diseases. Therapy centers on intense moisturization and keratolytics like urea or salicylic acid. Our next pattern involves intensely pruritic, purple, polygonal papules and plaques. This is the classic textbook description of lichen planus. Lichen planus frequently involves the oral and genital mucosa, where it features a distinct, lacy white network of lines known as Wickham's striae. It carries some extremely high-yield disease associations as well, most notably hepatitis C, and it can be directly triggered by medications like ACE inhibitors or thiazide diuretics. You also need to watch for the Koebner phenomenon. This is a vital diagnostic clue where new dermatologic lesions actively form along lines of minor skin trauma or scratching. You'll see this prominently in both lichen planus and psoriasis. Lichen planus generally resolves spontaneously within weeks to months, usually leaving behind some residual hyperpigmentation. Your first-line management relies on high-potency topical corticosteroids for symptomatic control. To wrap up this Step 2 review, let's quickly cover two other high-yield presentations you have to recognize. First, erythema nodosum. This causes tender anterior-leg nodules from septal paniculitis without vasculitis, and it's heavily associated with strep infections, IBD, and sarcoidosis. Finally, lymphedema. This presents as swelling that progresses from pitting to firm, non-pitting edema with a positive stemmer sign. Treat it with compression and physiotherapy. And that covers the high-yield decision logic for these key dermatological conditions.